Right, that looks everybody from the waiting room. We've got everybody in nice and quick. People can join as they come in from now on. So good evening, everybody. Welcome to this evening's Improving Childhood Asthma Management ICAM Community of Practice. And tonight we're really excited to have some experts in vaping chat to us. If you're anything like me, who is a GP, who doesn't have a lot of patients who vape, this is an area where definitely I am excited to expand my knowledge. So we'll kick off the evening with our usual acknowledgement of country, and in the spirit of reconciliation, we acknowledge the traditional custodians of land on which we meet, the Wurundjeri people of the Kulin Nation. We pay our respects to the elders past, present, and extend that respect to all Aboriginal and Torres Strait Islander peoples here today, for they are safekeepers of memories, traditions, and culture. We recognise their connection to country, land, sea, and community, and the role in caring for and maintaining country for thousands of years. May their strength and wisdom be with us today. Just a little note on housekeeping. If all attendees can be muted, there'll be opportunities to ask questions. Feel free to ask questions via the chat box. Sometimes we open up for discussion, and we're very happy to do that as well. But if you can keep it muted while people are presenting, that'd be fantastic. Session is being recorded, and you can access the recording in the post show notes that will be emailed out to you. So please ensure you join using the session name that you're registered with. Otherwise, we can't mark your attendance for your CPD hours. So just a brief slide you can look for on how to change your name in a Zoom meeting to make sure it aligns with the name you registered with. Just click on participants, click on your name. If you've got the app on the desktop, hover over your name and click the three dots, and on Mac, hover over your name and click more, and then rename. Just have a quick look at that. So I'm Kirsty. I'll be doing the welcome and housekeeping, and then we have access to therapeutic vapes in Victoria, regulatory overview, the pharmacology and cessation strategies, presented by Jared, one of our working group members and fantastic pharmacist. Then we'll move on to the presentation by Nikita from the use of vapes in the community, a pharmacy perspective, the emerging evidence and the harms of vaping, research on vaping use, and the current pharmacy landscape and community use of vapes. And then we've got a great case study from Libby Spears from our co-health asthma team. I'll be summing up and going through the new changes to health pathways and talking a little about the community asthma programme. And then we'll be doing some wrap up and feedback about the next community of practice. So hopefully by the end of the session, you'll be able to implement best practice in the management of asthma in children in the context of vaping, describe resources and local services available for children living with asthma, identify collaborative, multidisciplinary opportunities to improve care for children living with asthma, and interpret some local data and identify potential solutions to improve asthma care. So I'd love it if everybody could introduce themselves in the chat. It gives us a really good idea on the demographic who has attended today. If you go down to your Zoom bar and in the chat, just pop in your name, your organisation, and your role. So introducing your facilitators. Unfortunately, Catherine is on ward duty today, so I'm not sure that she's able to join us. She's off looking after little sick kiddies with asthma. I, however, finished work earlier today. I'm Kirsty. I think a lot of you know me. I have been GP facilitator of the ICAM working group for the last 3 years. I'm a GP from Truganina in the western suburbs of Melbourne, where we see a high incidence of asthma and allergy, and I work primarily with the paediatric population and have a specialist interest in asthma. So I'll introduce Jared now. I'll let him tell you a little bit about himself and get into what should be a really fascinating discussion.
Thank you. So as already stated, my name is Jared. I'm a pharmacist. I work for the Pharmaceutical Society of Australia, and recently in the last 18 months to 24 months, there's been regulation change around access to vapes, and much of that regulation change has meant that what vapes that are legally available are only available from pharmacies. So it means that a lot of the responsibility around access now is falling a lot on pharmacists, both for Schedule 4, which is prescription, and Schedule 3. So let's get into this. I'm going to cover a couple of things I'll just touch on this overview slide. We can talk a bit about the pharmacology nicotine, the types of vapes that are available. I've already got an error that I detected, which I should have detected earlier, which is black market versus notified vapes. The black market is still a big part of this. And when we say black market in this space, it just means regular retailers. Regular retailers have vapes available for them, but they're not legal. I will talk about vapes as a cessation tool, both for smoking and for vaping itself, keeping in mind that this is considered to be last line therapy. People should really try other things first, and you would go to vapes as an option if they've tried other things, or they're definitely not going to engage with anything else and are just going to smoke otherwise. I'll talk a bit about motivational counselling, and there'll be some discussion about the different access models for both Schedule 3 and Schedule 4, and then we'll hand over to my colleague Nikita. So if we go on to the next slide, I will just let you know that I'm going to try and go relatively quickly on these topics. I'm very, very happy to go into more detail if people need it. So if I touch on anything and I don't go into enough depth, just let me know. And also I can do it offline later on as well. So nicotine itself, we need to understand how it works. It is a nicotinic acetylcholine receptor, an agonist and antagonist. So what this actually means is, first of all, it's a fairly primal neurotransmitter. So just about every animal has nicotine affecting its neurobiology. That means that basically when you have nicotine, it's affecting many different systems in the body, but the area that we're most interested in from a dependence point of view is how it interacts with the brain in a way that creates a reward mechanism that makes you think, great, I smoked and it was a great idea, I should do it again. And the same goes for vaping. When you inhale a vaping product, you get a nicotine influx into the brain, and the brain goes, that was such a good idea, you should do that again. And part of our jobs is to try to help people overcome that part of their brain that tells them that. It does work as both an agonist, which means it stimulates the receptors that it works with, and then afterwards, after it's worked as an agonist for a period of time, it actually does become an antagonist. And that's due a bit of the complex nature of the type of receptors and synapses that are involved in nicotinic innervation. So what ends up happening is nicotine floods the areas of the brain and the nerves and the receptors on those nerves that want to receive nicotine, but after a while it stops responding to them. And the on and off of that effect is quite rapid. So that's part of the reason why people feel satisfied when they smoke, and when it wears off again, why they want to smoke so quickly again. We also get a thing called neuroadaptation, and I'll talk about this in a little bit, but basically the receptors for nicotine increase the more you smoke or the more you vape, and you also get dependence, because once you've increased those receptors, the brain goes, well, you better fill them. And so you keep wanting to have more and more nicotine so that you don't feel withdrawal symptoms occurring. The withdrawal symptoms are the biggest influencer of a person's success in quitting if we only look at it from a chemical perspective. The other thing that's worth noting is that nicotine does have quite a high bioavailability. That means when you consume it, your body takes up a lot of the dose. And from the perspective of inhaled nicotine, so that's both smoking and vaping, that bioavailability is very, very high. And so you get this rapid absorption of nicotine at quite a high percentage of the dose that you inhaled, and that leads to rapid response to nicotine. That's why if you smoke or if you vape, you get a response in less than a minute. Now, this slide, if we move on to the next one, is a picture of the brain. And it shows us sort of the processes that are occurring in the brain when we take in nicotine. So we inhale the nicotine into our lungs, and the bloodstream picks it up, and that delivers it straight to the brain. The area of the brain that receives that is called the ventral tegmental area. It's not the only part, but it's the part that's important for dependence and our reward system. And so these receptors that respond to nicotine in that area of the brain go, okay, I've been hit with nicotine, what am I going to do? And it innervates into another area of the brain called the nucleus accumbens. And this then leads to further innervation in the prefrontal cortex, which is your decision area of the brain. And dopamine gets released, which is our reward mechanism. So you inhale a nicotine source, and the brain releases dopamine. Dopamine is the same neurotransmitter that's responsible for other types of dependence, such as gambling or alcohol or pretty much any other dependence you can think of, especially behavioral type ones. I don't want that to make that sound like dopamine's a bad thing. It's used in multiple areas of the brain, but it is the reason why nicotine, when you inhale it, creates such a dependent response after a very short period of time. One area that I'm not talking about too much depth in this presentation is our genetic variation that occurs in this space. There is definitely genetic variation, and so for some people, they actually need really high doses and exposure of nicotine to develop a dependence based on their way their genes create enzymes that break down the nicotine. And in those individuals who take a long time to develop a dependence, they're actually harder to shift once they've developed it, which is a tricky process to work with for individuals who are trying to quit. If we move on to the next slide, this one shows us what neuroadaptation is. So on the left side, we've got these Y shapes are the receptors. The yellow bit is the nerve cell, and the little pink dots are nicotine. And so what actually happens is the nicotine is normally in contact with those receptors based on the nicotine that our body creates and nicotinic innovation that our body already produces, and also some nicotine comes from food. But once you smoke or vape or have nicotine from other sources, because you've got so much nicotine there and you're creating this response in the brain, the body decides to create more receptors in response to the higher concentration of nicotine. And then when you take it away, all those receptors go, no, 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 you're supposed to be giving me stimulation. Why aren't you anymore? And that's where withdrawal symptoms come from. It's come from all these receptors that are basically feeling neglected. When we work through a structured withdrawal process, so that is using NRT, for instance, and motivational counselling, over time, those receptors downregulate again. That is, our body destroys some of the excess receptors that we don't need, and we go back to let's say, a normal state, so to speak. What's really important from the perspective of health professionals or individuals who are trying to quit smoking, if you're providing counselling to people who are about quit smoking and they say to you, for instance, I've got this NRT product, nicotine replacement product, and it doesn't really seem to work very well, I'm still getting some withdrawal symptoms, that's actually by design. What we actually want to see for somebody is not quite the same amount of nicotine that they're getting from smoking or vaping, so that they start to down-regulate these receptors, and then the receptors that aren't being used get metabolized, and then you step down your dose gradually over time. I might say while we're on this slide as well, this is actually one of the reasons that using vaping to help quit smoking is so tricky, because the amount of nicotine we get from vaping products is substantially the same as what you get from smoking. And so you don't get this ability to lower the exposure to nicotine that allows these excess receptors to be reabsorbed back into the nerve cells. And so it can be a very long process to quit smoking with vapes. And if you're vaping already and trying to use therapeutic vapes, it can be quite a long process as well. Okay, let's move on to the next slide. I might just note, I'm looking at a separate screen too, where everybody's hand might go up. So if we do get a question, maybe let me know. But hopefully I can be explaining this well enough that we don't get too many questions. How about that? Okay, so let's talk about the types of vapes that are available in Australia. So most of the things that people will see are actually what we keep referring to as black market vapes. These are sold by regular retailers. They are not sourced from a regulated source. They might be well produced, but the majority of these devices are not. And so what we're seeing in practice is devices that contain very high doses of nicotine. They contain flavors that are designed to be enticing, not just to kids, to adults as well, but definitely enticing to kids. The types of nicotine that are in there are designed to make them as bioavailable as possible, because the people who are making these devices want a continued source of income. So the more quickly you become dependent on the nicotine in these products, the longer they've got you as a customer. The other thing that's really important to note is that the batteries in them can be very poorly matched. So that is, they might have multiple batteries in there that are not designed to be used together, and that leads to things like leaks and even explosions. And so I'm not recommending people do this, but if you look online at images of vaping injuries, they are all to do with explosions of these devices and the batteries that are in them, and they can be very dangerous, third-degree burns and things like that. The other part that's worth noting is that they contain other contaminants that have been found in these devices, such as heavy metals. There's a term called an adjuvant that you can see on the screen here at the moment. An adjuvant is something that's designed to make the active ingredient more effective, more bioavailable, or in this case, more likely to lead to dependence, which is not great. They also contain propellants or vaporizing ingredients that are not approved in the therapeutic vape. So ethylene glycol is one of those. So in a regulated vape, we talk about propylene glycol and glycerol, and that's the same kind of ingredient you'll see if you go and see a band and they've got a smoke machine on stage. Ethylene glycol is more associated with more side effects, especially in the oral cavity, so mouth, gum, and teeth disease. Now, if we compare that to the therapeutic vapes, the therapeutic vapes, first of all, they are not demonstrated to have a clinical impact. Nobody has presented to the Therapeutic Goods Administration any evidence to show the safety or the efficacy of these as far as dependence or quit smoking is concerned. But the government has taken a position that it is better to have a list of products that we know are well manufactured that prescribers might make available to patients if they're going to do that in a medical scenario, or in some states available over the counter from a pharmacist only, and that includes Victoria. We can sell these in a pharmacy as a Schedule 3 product. There is a specific list of these products that can be sold in this way or prescribed, and that list does change from time to time, and the regulations around them have gotten a bit tighter over time. So the most recent changes, for instance, have changed what color they're allowed to be. They now must be white, looking sort of like a turbihaler, I guess, in color, so that they look more like a medical device, not a consumer product. They're not allowed to have fancy lettering or anything like that on the device or on the boxes. The boxes need to look like a medicine type product, not a product covered with fancy lettering, colors, or logos and things like that. That again, to reduce that enticingness of these products. In addition, the flavors can only be the ones that are on screen now. So that is mint, which is either peppermint or spearmint, menthol, tobacco flavored, ironically, and unflavored, which just means it's only got nicotine, propylene glycol, and that's it. Most of the products that we see are menthol or mint flavored ones. And so there is this standard. The standard is called TGO 110, and that is a manufacturing standard. It is not a health-based standard. It is not saying, you must have demonstrated that it is effective at quit smoking or quit vaping. It's got none of that requirement for evidence, which means these products are what we refer to as being off-label. They're not technically approved for human use, but there is a pathway to access them. And if and when a manufacturer of these products ever provides enough evidence to the Therapeutic Goods Administration, they might get listed as what we call an ARTG listed product, like every other medicine that we would expect to have that level of safety and evidence around them. It's also worth noting that the devices themselves are regulated in this space as well. So the devices are not allowed to be in a format where you have to change them after you receive them. So that is, they can't be dilutable. If you go online and look at what they use in America, for instance, many people will purchase these devices and they'll purchase liquid nicotines and flavors and all types of different things, and they mix them up themselves. And the reason that is not allowed in Australia is because the few deaths that have ever been recorded from nicotine as the sole source of death or injury has been from children that have gotten a hold of that concentrated liquid nicotine, and they absorb it via their hands, and it leads to quite serious outcomes, including death. And so these devices must be self-contained. There is a version you can get that has a cassette that goes into a device, but those cassettes are not modifiable either. And so the end result is that most of these are single-use products, as in they might last you a week or a month, for instance, but they can't be reused after that. And that leads to quite a large impact on the environment. They are not recyclable, and people tend to throw them out the car, as you might see if you're driving on some of the bridges in Melbourne. Cigarettes are also a huge environmental impact, but these are more so because they're made of plastic as well. All right, if we move into, so vapes is a cessation tool. So, excuse me. The first thing is vaping is used overseas. So especially in England and the UK, sorry, they've got these things called the NICE guidelines that acknowledge the use of vaping as a smoking cessation tool. And one of the reasons that we are able to use vapes in Australia as a therapeutic product is for dependence. And so that is if a person is smoking and can't quit smoking from any other source, and they transition to a vaping product that is on one of that list, the TGA 110 list, it is considered to be a lower form of risk and less harmful because vapes don't contain all the cancer-causing agents, all the ingredients that suppress the function of the cilia and the lungs. They still have health impacts, but as a comparison to smoking, less harmful, not without harm. It's important to note that. They can also be used for smoking cessation as a approach to a time-based intervention. So that is, smoking cessation is you're going to start with your smoking, you're going to transition to therapeutic vapes, and then you're going to cut down your dose over time and cease altogether. So that is very similar to the approach that we use for nicotine replacement therapy. The difference is that nicotine replacement therapy, patches, gums, lozenges, etc., those have an evidence base and they are approved for that use. Any use of a therapeutic vape in this space is at the discretion of the practitioner and the patient, and there is a risk associated with that for the practitioner, medical legal risks. It is also important to note that if we're going to quit smoking, we are obligated by law to refer people on to other support mechanisms. So if we're talking about Schedule 3 supply, pharmacists must refer to a GP, they must refer to Quitline. They have to talk to the individual about the fact that this is there's no evidence for the benefit of this product and that it's only regulated from a manufacturing process, not from an efficacy process. And so this is part of informed consent. And so the outcome of that should be that if you are speaking as a pharmacist to patients who are requesting vaping products, it takes you 15 to 20 minutes to go through this process. Many people aren't going to want to do that, and they might take that opportunity to say, well, let's go with some of the evidence-based products that we've got available. Regardless, we're always referring back to the GP. There is a strength limit as well. The vaping products that you can sell without a prescription maximum strength is 20 milligrams. So anything stronger than that a person might need requires a prescription. It is worth noting that there are other products that are considered first line, and that if we have somebody asking us about vaping products as either a prescribing practitioner or as in pharmacy, for instance, we're obligated to talk about those and refer on. So that includes things like varenicline, cytosine, which is not really available in Australia either, and NRT. The other thing that's worth noting is that quit smoking using vapes is not evidence-based, but now we do have evidence-based for quit vaping products. And so there is a product that's available from pharmacy at the moment that is now listed with the TGA to help people quit vaping as well, which is a spray into the mouth that gives you a nicotine response that's quite similar to smoking and vaping. So that product's been around for a long time for smoking cessation and is now available as well as a quit vaping product as well. And it's worth noting as well that the two prescription products are available in Australia, so varenicline and bupropion. They are not technically listed with either the TGA or the PBS for vaping cessation, but they're accepted in that way, and the prescriptions will be funded by the government for those. All right, let's move on to the next slide. I really want to focus on motivational counselling techniques. So motivational counselling techniques sort of come in sort of two separate flavors, if you want to say that. One is the short interventions. which is what many health professionals are going to have the opportunity to provide. So, for instance, I've gone and spoken to dentists and oral health technicians, and I've said to them, if you're providing a service to a person who clearly smokes, or that you can determine is vaping, you should be asking them every time, have you thought about quitting? And when they say no, you say that's fine. And the next time you see them, you say, have you thought about it since we last spoke? And over time, those conversations will lead to somebody saying, actually, do you know what? Tell me more. And that gives you the opportunity to either spend more time talking about quit smoking, quit vaping, or to refer to them to somebody who can actually provide a more comprehensive service. So there are aspects to motivational interviewing that go into a more comprehensive service. It takes about 15 to 20 minutes and is supported by things like Quitline, for instance. It really is about reflecting upon the person, what their experiences are. You don't have a person come to you for quit smoking and say, you should quit, right? If you have that approach, they're not going to come back to you. It's about developing empathy. Develop discrepancy. I'm not sure what that's a mistype in there. I'm not sure where that came from. But the whole point of motivational interviewing is to work with that person to understand where they're coming from, understand what their trigger factors are for smoking, why they want to go back to smoking or vaping, and then to work with them to overcome those things over time. We're using open-end questions and affirmations. So yes, I understand the scenario you're in when they talk to you about different things, and reflect back to them their experiences and the things that they tell you, so that you are showing that you're hearing what they're talking about. There are motivational counselling courses available throughout Australia that are open to all health professionals. Quit does provide that kind of training, as does Alfred Health here in Victoria, and other providers. So anybody who's interested in providing additional services for quit smoking and quit vaping, then it's a really good training to undertake. I know that it's very effective for school nurses, for instance, people who are encountering young people who are smoking or vaping. The impact that it can have is really enormous. Let's move on to the next slide. So the other aspect of this that we need to keep in mind is, what is the evidence base around quit vaping? And the reality is that there's not a lot of evidence base around quit vaping. Not a lot of work has been done in the space of research for quitting of vaping, but it is considered by most people in this space to be similar to quit smoking. And so we have the same approach to it as we would for other people who are smoking now. If they're smoking, you would go through a particular approach, and if they are vaping, we can take the same approach. The models that I've got on screen here are some of the ones that are already utilized for quit smoking. I might focus on the Fagerstrom one because it's one that people might be familiar with without knowing that they're doing it. And that is, when you say to a person, how soon after you wake up do you want to smoke? They'll say 30 minutes. As soon as I wake up, I want to have a cigarette. Or as soon as I wake up, I'm thinking about my vaping device. And that is the Fagerstrom model of determining how dependent a person is on their nicotine. And it is applicable to both smoking and vaping. We do need to tailor our interventions to the device type that they're using in the nicotine dependence level. For many people who are struggling to quit, the dependence level will be high. And so what that means is, in practice for a pharmacist, it's unlikely that the Schedule 3 strength is going to be the best option available to most people who've tried other forms of quitting and failed. Really, the only place where the Schedule 3 strengths are going to be commonly used are people who want to quit either smoking or vaping and don't want to try any of the other products. And if we don't assist them with something, they're just going to go back to vaping or smoking. But for most people who've tried to quit several times without success, they usually need a higher dose level. Regardless of what product they get, they do need that support from Quitline. Quitline and the other versions that are in some other states doubles the quit rate. And so if we don't have Quitline helping a person, we're halving their likely success rate, which is not something we want to do. We want to increase that as much as we can. When we talk about those quit smoking approaches, though, part of it focuses on people's health. So we'll say to people, what is your health aspects that you want to get out of quitting? And they can usually tell you, I can't exercise as much as I used to, or I can't spend time with my kids because they get puffed out too quickly, or they're noticing that they're wheezing and things like that where they haven't before. Or very relevant to this particular area with ICAM, I've got kids in the house and I don't want to be vaping or smoking around them. So that is a really important aspect of both quit smoking and quit vaping. A particular difference, though, that we need to understand when we're talking about quit vaping is that we quite often will talk to people about their smoking and its effect on their appearance, so their look and their smell, because they'll smell like cigarettes, their hair, their skin, their teeth. All these things are affected, their fingers and their fingernails. You know, you'll see people who've got the yellow fingertips, for instance. This is not usually the case with vaping. And for some of these vaping products, because of the very pleasant smell of them, the way they're designed to be enticing to, especially the kids, for some people, they smell better when they're vaping. And we can't really use this as a thing to help motivate people to quit. But there are some aspects of vaping that we do know are starting to have an impact on people. Nikita will talk about a little bit about this as well. But one of the things from a health aspect that we do know is that people's exercise capacity is reduced, especially if they've just recently vaped, because the propellant or the vape itself, the propylene glycol, leads to a reduction in their lung function for a period of time until they expel it all out, because it's quite heavy. And so people can't do things like go upstairs or play sport the way that they normally do because their ability to exercise is reduced. And so that can be very motivating for people, especially if they're younger. They don't want to be thinking of themselves as unable to exercise or do what they want to do. Okay, if we move on to the next one, which is the access models. So I just want to briefly touch on this because it's important to know from a Victorian perspective. So if you are talking to a person who is saying, listen, I really need to quit either smoking or vaping, and they don't really want to engage with the doctor, they can get these things from a pharmacy, but I would encourage as much as you possibly can to speak to their regular GP first. That's what a pharmacist will be doing. By law, we're required to refer them back to their GP in this instance. So we might, for instance, provide them with a low strength nicotine vape, but we're always going to say you should also now follow up with your doctor as well. In Victoria, people under the age of 18 can receive therapeutic vapes, but only as a prescription product. There is a form that must be filled out when using these products. It's called a special access scheme form, and for the majority of individuals, that's going to be one that we call SESC. That is, we're letting the government know that we're using the product. We're not getting permission, we're just telling them we've used it, and we do that for every individual. And so that adds to the time taken to do one of these consultations with the person. The trickiest part of this is determining what strength of a product they're actually going to need. And in practice, what we're seeing pharmacists do is they'll keep one or maybe two products on their shelf. They won't keep a very large range, and they'll get familiar with that product, and they'll start an individual with that one, and then they'll ask them how long the device lasts. Because one of the things we know about nicotine from a vaping device is that people will titrate their dose up to the level that gives them relief from withdrawal symptoms, which means that the strength becomes less important than the amount of time they take to use up a device. And the quicker they go through a device, the more important it is for them to get a prescription for their product, because otherwise it's going to become very expensive and a high level of exposure. Let's move on to the regulatory requirements for Schedule 3. So I'm going to go through this very quickly. Before I can supply as a pharmacist a Schedule 3 product, I've got to go through all of these aspects with a patient. You can see there's quite a number of dot points there, right? So I need to talk about the fact that there's no evidence base for this. They've got to confirm that they're over the age of 18, and I must check their ID every time. I can only provide within any 1 month period the maximum that would be needed in 1 month. So I can't just say to them, here's 7 boxes. That wouldn't be appropriate from multiple aspects. I must refer them to their GP. I must refer them to Quitline. These are not optional. These are actually part of the legislation. So in practice, I must be doing this every single time. I've got to get their informed consent, which means if I don't give them all the data, all the information, and they come back a week later and say, I didn't realize it was going to do this, this, or that, then I failed in my role. Understanding, though, that not everybody's going to take in all the information, and we want them to come back and ask more questions later on. And what I do in practice, although I haven't worked in vaping yet, but in the quit smoking space, I always say to people, here's a whole bunch of information. Here's the thing that we're going to do as an intervention. I want to see you in 3 days, regardless of how things are going. And I want to follow up with them and keep them on track, if that makes sense. All right, let's move on to the next one, which is Schedule 4. As far as Schedule 4 is concerned, the prescription in Victoria can be written by a medical practitioner or a nurse practitioner. This allows for, in addition to any person who would benefit from that therapeutic relationship with a doctor or a nurse practitioner, it does have other areas that you can prescribe for as well. So that is people who are under 18, people who really need very high concentrations of nicotine. And what we will likely see that with people who've been vaping for a very long period of time and who go through their vape device very quickly. The reason for that is many of the black market vapes are designed to give you very, very high doses of nicotine in order to make as many people dependent as possible. That's their business plan, right? And so anybody who's been vaping for a long period of time will actually likely need a higher dose therapeutic vape than the kind that would be available without a prescription. And that lines up, right? If they're highly dependent, we want as much support for them as possible. The access is via either this special access scheme, or doctors can nominate themselves as a specialized practitioner in this space. That just means there's less paperwork for them to do. So if a doctor found that they were seeing many patients for vaping and they had a particular interest in that space, they would be able to fill in a whole bunch of extra paperwork, but then they wouldn't have to do as much paperwork afterwards for SAS. The requirements that were on the previous slide technically don't apply to the Schedule 4 mechanism, but I would say this, they should be read by a prescriber as being, these are the kind of things that the government expects are part of a conversation about the use of a therapeutic vape. And therefore, while it's not part of the legislation for Schedule 4 supply, it is definitely recommended that a prescriber would go through the same kinds of processes. Okay, let's move on to the last slide, which is the summary and key takeaways. So just a reminder, nicotine is highly addictive. This applies to both smoking and vaping. This is probably not a surprise to anybody who's coming here, but the reason I reiterate that is because it's important for every person who's helping somebody to quit, is that the people need assistance to quit, not because they're recalcitrant, they're not lazy, they're not trying hard enough, all these things. Nicotine gets a hold of people really effectively. And so we need compassion and empathy for people who are trying to quit. And if somebody tries to quit and then goes back to smoking, or tries to quit and goes back to vaping, that's okay. Let's just start again. It's not the end of the world. It's the start of the next quit cycle. It's also worth noting that therapeutic vapes are a slightly safer alternative than smoking, and they're a slightly safer alternative than black market vapes. And only from the perspective of vaping products don't contain many of the carcinogens that are in smoking, where it's important to note that nicotine does increase the growth of some types of cancers, but they don't cause them. So it's not without risk in the cancer space, but they are far less associated with cancers than smoking is. And as far as vapes are concerned, they're less likely to explode in your face or in your pocket and things like that, but not without some risks as well. And so when we say these things are safer, we're comparing them to something that is extremely dangerous, like smoking is very unsafe. Anybody who's working in this space, if you are a prescribing practitioner and you want to work in this space, you really do need to familiarize yourself with the list of vapes that are allowed to be used. It's called the TGO 110 list. And I'm happy for anybody to reach out to me if you want to get more details on that. We can provide that. You can use vapes as a cessation tool, but the process usually is this. Let's get somebody into thinking about quitting. If vapes is the way they want to quit, that's fine. But over time, you're going to transition away from vapes as well. Anybody walking away from this particular discussion who thinks, yes, vapes are a great option to help people quit, I haven't done my job. You should think of them as your last line. They are available for anybody who otherwise would continue to smoke, but other options are safer, more evidence-based. The next slide is my references. I think everybody should get access to them. You don't want to read them now. And then I'll stop talking.
Fantastic. Thank you so much, Jared. I feel as if I can speak for the audience. I hope in saying that my knowledge on vaping has just exponentially increased. I certainly have a lot of questions. Nothing has come through in the chat at the moment. I think there was a lot of information to absorb and put into clinical practice. I'm not going to set the questions off immediately because Nikita may actually answer some of them in her talk. So let's have Nikita present, and then maybe we can open questions from the pharmacy side of things before we hear about Libby's case study. So introducing Nikita Dalla Venezia, and she's going to discuss the use of vapes in the community from a pharmacy perspective.
Thank you. Good evening, everyone. That was a tough act to follow, Jared, but I will do my very best. Hello, my name is Nikita Dalla Venezia. I'm a public health professional and project manager at the Pharmaceutical Society of Australia. And I'm actually not based in Victoria. So before I begin, I'd like to acknowledge the traditional custodians of the land that I'm coming to you from this evening. That is the lands of the Ngunnawal people. Perfect. All right. I think we're on to the next slide, please. So I don't want to reiterate or harp on too much about what Jared already spoke so eloquently about, but I do want to begin by providing a bit of context for anyone who perhaps isn't familiar with vapes, although of course you now already are. But e-cigarettes or vapes are battery-powered devices that deliver nicotine or other substances in an aerosol form. And historically, these have been marketed as a less harmful alternative to smoking because they avoid combustion, so that process that generates the tar and many of the toxic chemicals in traditional cigarettes. And this narrative has positioned vapes at what I think is a fairly interesting intersection as both a tool for harm reduction and as a new vehicle for consuming nicotine. And there is some evidence that vapes can be used as a smoking cessation tool for certain individuals. However, this message of less harm or no harm has also been used by manufacturers to market products in a fairly aggressive and quite appealing ways, often targeting younger demographics. So vapes come in really sleek designs. I'll give them credit for that. They come in sweet flavors, and of course, they're really bright packaging, all of which is very different from the plain packaging and strict regulations that we associate with cigarettes. So globally and here in Australia, vaping uptake has been rising year on year, with youth identified as a major driver of this trend. The rapid uptake in adolescents raises important concerns about the long-term nicotine dependence, as well as broader public health impacts. And for pharmacists and arguably all frontline healthcare professionals, to be honest, the management of nicotine dependence intersects with the use of vapes by people recreationally. And as Jared mentioned, under the Schedule 3 framework, pharmacists are now expected to play a role in balancing harm reduction within the context of the new vaping regulation. So before we look at the evidence of harms, I do want to start by drawing that really clear line that Jared already touched on between a therapeutic vape, which are regulated and used in cessation, and illicit vapes or black market vapes, which dominate the market but do not meet the same standards. So that distinction is really important because it's a factor to consider when we're interpreting the research that I'll be taking you through this evening. Next slide, please. Oh, apologies. This is just kind of touching on what we've already done. But again, want to make it really clear. So therapeutic vapes are not TGA approved medicines. They haven't been formally tested for safety or effectiveness, but sponsors must declare that they meet strict product standards, including permitted nicotine concentrations, only the approved flavors, as Jared mentioned earlier, proper labeling, and child-resistant packaging, which is really important. So these safeguards make them fundamentally quite different from illicit vaping products. And as I mentioned, illicit vapes, in contrast, they don't meet any of these standards. They are frequently mislabeled. They often contain unsafe levels of nicotine or contaminants such as heavy metals. As Jared mentioned, we've found lead in some of these products, which I find really alarming. That always sticks out to me. And they're deliberately packaged to appeal to young people with bright colors and novelty designs. So these products, they're unregulated, they're unsafe, and they're now illegal. And this distinction is really important because much of the research that we'll discuss tonight has been conducted on illicit or non-compliant products. And if we present that evidence to patients without the context, there is a risk of alarming patients or creating the perception that all vapes are equally harmful. And that just isn't accurate. The evidence doesn't support that. And for some people, therapeutic vapes can play a useful role in smoking cessation when clinically appropriate. So for people who smoke and are seeking nicotine replacement therapy, therapeutic vapes, they're not completely free of harm, but they're likely to be less harmful than smoking cigarettes. And that distinction is really important to make quite clear to individuals. All right, we'll move on to the next one. Thank you. So we'll start by looking at the respiratory harms of vaping, which I think is the most logical place to begin because it's where the vapor has the most direct impact. So research has consistently shown that regular vaping is linked to poorer lung health, even in people who have never smoked cigarettes before. And people who vape often report increased coughing, shortness of breath, and reduced ability to exercise, as Jared mentioned, compared with non-users. And for people with pre-existing conditions like asthma or COPD, vaping can make things significantly worse. So clinical studies have shown that it increases airway irritation, it increases wheezing, and it triggers asthma flare-ups. And we also see that people with COPD who vape tend to have more frequent symptom exacerbations. And that means that vaping doesn't just carry risks for otherwise healthy lungs, it also makes existing respiratory disease harder to manage. And a major factor of this is the chemicals in the e-liquids. So many of the flavoring agents, again, in the illicit vapes, they're safe to eat, but they're not safe to inhale. And our lungs are not designed to cope with chemicals in that way. So lab and clinical studies have shown that e-cigarette aerosols contain a wide range of irritants and toxins. Not only do these irritate the airways, but they can inflame and damage the cells of the lung tissue in ways that have been demonstrated to be similar to cigarette smoke. So heavy and prolonged vaping has been shown to promote inflammation and oxidative stress, which are recognised as contributing to chronic lung disease. It's also to remember the acute harms of vaping. So in 2019, there was a major outbreak in the United States, which later became known as EVALI, so e-cigarette or vaping associated lung injury. More than 2,000 cases were identified, and many of them required intensive care, and unfortunately, dozens of deaths were reported. Now, I do want to make it very clear that these were linked to illicit THC vapes that had been contaminated. And this was very much a localized issue, but I raise it because it highlights how poorly controlled products can lead to very sudden and severe lung damage. Now, of course, vaping is an area where evidence is still very limited. For example, we don't yet know whether vaping increases the risk of developing asthma or what the long-term effects of second-hand or third-hand exposure might be for children. But what we do know is that many clinicians aren't routinely asking young patients about vaping, which means that the harms could be going under-recognized. So when we look at the respiratory system, the evidence is quite clear. Vaping is not harmless. It can reduce lung function. It can worsen asthma and COPD, introduce new toxic exposures. And as I mentioned in the case of EVALI, it can cause sudden and severe injury. Next slide, please. Thank you. So the cardiovascular system, this I find quite interesting, where we can see that vaping has measurable effects. So I don't think I need to explain this to anyone here, but nicotine, of course, whether it's delivered through cigarettes or e-cigarettes or gums or pouches or anything that people come up with these days, it's a stimulant. So it raises blood pressure and heart rate, and studies have shown that vaping is associated with increased stiffness in the arteries, which places extra strain on the cardiovascular system. Research has also demonstrated that vaping promotes oxidative stress and inflammation in the blood vessels, damaging the endothelium. And of course, endothelial dysfunction is recognized as an early indicator of cardiovascular disease. So quite an important factor to consider. And what's really important is that these effects can be detected quickly. So as Jared mentioned earlier, even in young, otherwise healthy adults, short-term exposure to e-cigarettes has been linked to impaired blood vessel function. And this shows us that the risk of cardiovascular health are not only long-term, but they can occur after relatively brief use. Something I do want to touch on as well is dual use. So many people will take up vaping with the intent to quit smoking, but without fully quitting smoking. So the evidence shows us that cardiovascular risk in these individuals remains essentially the same as smoking alone. So when we're taking a harm reduction approach to smoking cessation, the benefits are only really seen when vaping fully replaces cigarettes. And we'll move on to the next one, please. Thank you. Apologies, I've got 3 screens going on, so try not to be rude. But Cancer risk. So Jared did raise this earlier. And again, this is an area that is still being studied and the long-term picture in humans is not clear. But I do think it's worth discussing. So e-liquids contain a mix of substances, as we mentioned, propylene glycol, glycerin, flavorings, and nicotine, depending whether or not they're illicit or notified vapes. But when they're heated, these ingredients release harmful chemicals, including some that are known to cause cancer. So lab studies have shown us that exposure to e-cigarette vapor can lead to DNA damage. It can increase stress on the cells, and it can change how the body repairs itself. And these biological processes are linked to cancer development. So a few animal studies have also added to this context as well. So mice that have been exposed to e-cigarette vapor have shown greater tumor growth in the lungs, bladder, and mouth tissue compared with controls. Now, as I mentioned, in humans, the long-term data is very limited because vaping is relatively new. However, I'm going to quote, and I'm going to read it out, a recent systematic review, because I think it captures it really nicely. There is no significant increase in cancer risk. However, there is strong biomarker evidence linking vaping with DNA damage, cell death, and tumor growth, particularly in short-term exposure. So at this stage, we cannot say that vaping causes cancer in people, but the evidence that we do have is enough for clinicians to be aware of these biological signals, and it highlights the need for further long-term and population-based studies. And just bringing it back to a public health message, the message is twofold, I think. So for people who smoke, vaping may be considered as part of a harm reduction pathway, but it is crucial for people to avoid dual use and to choose therapeutic regulated products rather than illicit products. And for people who have never smoked, the advice I think is quite different. So vaping does carry cardiovascular risk. It should be avoided. And preventing uptake in young people is particularly important given how quickly these effects can occur. Next, please. Perfect. So we're bringing it back to youth. So youth vaping in Australia was, vaping uptake among youth was a key driver of increasing vaping amongst not only the Australian population, but globally. And it was becoming quite a growing public health issue. So in 2022-23, survey data found that over a quarter of Year 9 students had tried vaping. And I'd like to remind you all, at least when I was in Year 9, I was 13, 14, so they're quite young, with 13% reporting use in the past month and almost 3% using vapes daily. And for vulnerable groups, the situation was arguably even more concerning. So among young people who were entering custody in New South Wales, 61% reported current vaping and over half were assessed as being nicotine dependent. So these figures really highlight how vaping and nicotine dependence disproportionately affects already disadvantaged populations. And this is really important for a number of reasons, but two that I'd like to raise. Nicotine exposure during adolescence can impair brain development, particularly in areas related to attention, impulse control, and addiction. And second, behaviours formed early in life often continue into adulthood. So if young people establish nicotine dependence through vaping, they may carry this addiction with them to the long term, increasing the likelihood of smoking initiation later on in life. Next, please. Thank you. So I think it's really important that we understand why vaping has become so popular, and to do that, we need to really understand its appeal. And for those of us working in the space, that can be a bit tricky, but I'll try to unpack it a bit for you here. So we've talked about the flavors. The flavors play a substantial role in attracting and retaining young users of vaping products. So products that are sweet, fruity, or dessert inspired specifically have been found to appeal to adolescents, and they mask the harshness of nicotine. So they make that initial experimentation more palatable and potentially reinforce that further use. And descriptors like strawberry milkshake or grape ice have been shown to have a stronger appeal in younger age demographics. And peer influence also matters. I think we can all remember how important it is to be accepted by our peers. Young people are more likely to vape if their friends do, and vaping has become a social activity in a lot of circles. Social media platforms like TikTok or Instagram, they really amplify this association as they associate vaping with a positive lifestyle, and even as a fashion accessory, which of course it really downplays or completely minimizes the risk entirely. And risk perception is a driver of uptake. So 2022-23 data indicated that many adolescents believe that vaping is much safer than smoking, if not completely safe. and some didn't even realize that they were consuming nicotine because they weren't accurately labeled. So this creates a perfect storm of factors, really, that normalize vaping and contribute to its uptake amongst youth. Next, please. All right, so access to vape products was a key driver of use, and I'd say is still a key driver of use. We've not quite squashed it out just yet. If you go to the shops on George Street in Sydney, you'll see them. But adolescents continue to report that obtaining products through friends, online sellers, or retail channels that do not enforce age verification was a key driver of their accessibility to vapes. And as I've already touched on, the design of the devices, they're often very compact, they're flavor labeled, they resemble everyday objects, like you can get pen or lipstick type devices. And that really conceals them, and it just facilitates that regular use, particularly in young people. As I mentioned, there's a strong variation in risk perception. So a lot of adolescents aren't aware that they're consuming nicotine at all. They associate vaping as being completely safe, and they underestimate or completely negate its potential for dependence. So it really highlighted to us at the time the need for clear, age-appropriate public health messaging and evidence-based conversations with your healthcare providers as well. So what I hope you take away from this section of tonight is that understanding these determinants is important because it helps us recognize that youth vaping is not an individual choice, but it's severely influenced by a broader social and commercial context. Now we'll move on to the pharmacy landscape, if that's okay. Now Jared's already spoken to this a bit as well, but I might just bring it back to some of the data that we've found. So brings us to the present, I suppose you could say, where in 2024, October 2024, I remember it very vividly, the Australian government introduced the vaping reform. So under these changes, the therapeutic vaping products were classified as a Schedule 3 pharmacist-only medicine. So that meant that they required a prescription or pharmacist-only supply, and they had to be provided under pharmacist supervision. So the aim of the reforms was essentially to restrict youth access while allowing controlled use by adult smokers who may benefit as part of a cessation program. So pharmacists therefore played a dual role. They were responsible for protecting young people by limiting access while supporting adults who were trying to quit smoking. And then beyond that, they also have a role of contributing to public health messaging by correcting misconceptions such as, vapes are safe, they are harm-free, advertising and advising on safer alternatives such as other and approved nicotine replacement therapy, and advocating for a balanced regulation. So I'll just present some research that I think is quite interesting. Now, I'm a tad biased, obviously. So as a project manager, I worked on the nicotine replacement therapy guideline update for the PSA. This data was collected prior to our guidelines being published, and I do feel the need to make that very clear. But pharmacists found themselves at the center of these reforms, obviously. They faced what was quite a sudden increase in patient questions about vaping. So the model that is now recognised was not advocated for by the profession more largely. They did recognise that they had a duty of care and were excited about the opportunity for harm reduction, but they also felt quite uncertain and even apprehensive about providing these services with the limited evidence. At the time, our guidelines weren't updated. We did get them out very quickly, I'm quite proud to say. And the regulations, the workflows had to change quite rapidly. So there were mixed views on whether vaping products should be part of smoking cessation at all. Some of the participants in this particular piece by Lee and colleagues, they still continued to favour conventional ARTG-approved NRTs, and then some did see a role for vapes in very specific cases. But across the board, pharmacists emphasised the need for comprehensive training, practical guidelines, and patient education tools as well to support those evidence-based conversations. So there is practical concerns about the additional time and cost required to deliver these services. As Jared said, that conversation would take on average between 15 to 20 minutes. And of course, that's not remunerated in the current model. So I think it's safe to say the reforms were met with cautious engagement. Pharmacists wanted and do want to help, but they required a clear framework to support them and make them feel confident in that area of practice. And I might just bring us back to post-policy implementation. So I'm pleased to end on a positive note, which is always nice. The preliminary data But this approach, the preliminary data suggests that this approach is beginning to show signs of success as it pertains to youth access to vapes, which is very exciting. So these statistics that I've pulled here are from an ongoing Generation Vape study, and that's led by Cancer Council New South Wales in partnership with the Daffodil Centre and University of Sydney. So post-policy implementation, the proportion of adolescents who had never vaped had increased to 85.7% in Wave 7, and that's up from 82% in Wave 6. So that's the highest level recorded since the national data collection began in 2022. That's really exciting. And similarly, 93.9% of adolescents now report that they have never smoked. And I think we can all agree that that's a really positive public health outcome. And among adolescents who have vaped, only 26% reported buying their own vape in Wave 7, and that's compared to 36% in Wave 6. So a fair decrease there as well. And quite importantly, I think the awareness of vaping harms is also increasing. So 82% of adolescents now agree that vaping is unsafe, and 87% recognize that it is addictive. And I think we can also see that the social norms are shifting, which is really exciting. So in 2024, more than half of adolescents said that they would definitely not use a vape if they were offered one by a friend. And that's an increase from 40% in 2022, so a 10% increase there. So these trends suggest that these regulatory efforts are contributing to improved awareness among young people. And I think it does advocate that we should continue to maintain that regulated pathway. Next, please. Okay, that was a lot. Like Jared, very happy to speak offline to anyone who's curious. We talk about this all the time. It's not a bore to us. But while notified vapes are not formally tested for safety or effectiveness, sponsors must declare that they meet fairly strict product standards. And I'll also just note that the notified vape list, the TGA, is conducting tests on vapes that are on that list. So it's not necessarily as though they accept that documentation as is. They are going through and reviewing it. They haven't sort of disclosed what that process looks like, but I do want to mention that just to increase your confidence about the vapes on the notified vape list. So for individuals with pre-existing conditions such as asthma, COPD, vaping does appear to exacerbate symptoms, and that's really important to share with patients, I think, particularly for you in this area of interest. So just also pointing out that access to vapes does remain a key enabler of use. I understand that the TGA is working quite hard with Border Force to regulate that, but it's an ongoing conversation. So as access to illicit and black market vapes becomes more challenging for people, it is likely that pharmacists and therefore by referral GPs as well may start to have young people come and have those conversations with them. And again, just pointing out that the preliminary data suggests that it's positive. So there's a lot of negativity in the vaping space, but I think it's positive to say that we are having an impact and pharmacists are sort of at the forefront of that. So thank you. And I do have all my references there. If anyone's curious, very happy to have a chat.
Fantastic. That was so interesting. Thank you so much for your time and your expertise. I'm just monitoring the chat here. Some questions. So, Libby, we've got half an hour. Are you happy if we take 10 minutes to do some questions? I'm going to kick off the questions if that's all right. What both those talks have highlighted to me as GP, and this echoes discussions we had within the working group, is pharmacists really lead the way here on knowledge and experience. I think that sounds like it was thrust upon you. Thank you. It also sounds like you're doing a really great job. You two obviously are experts. Do you think the pharmacy community, perhaps not as well educated as you two are being experts in the field, but how do you think the rest of the pharmacy community is managing, and I use the word burden, it sounds very similar to stories that we can identify with general practice. Here, you guys do it.
Yeah, you're right on the ball there. So the uptake is fairly low, and that's driven by a few different things. One is there's a hesitancy to be involved because therapeutic vapes have got a long way to go before they've got a really good evidence base. And so pharmacists are cautious about being involved in something that has low evidence base, high regulatory burden, high medical legal burden. And there's also some issues around the fact that the demand is still not there yet either, because I live in Caulfield. It's not exactly a small area, but I can walk from here down 3 blocks and I can find 5 places that will sell me vapes right now. So it is going to change over time, the amount of interaction my pharmacists have in this space. It's great that the education is available now, but we're going to see sort of a staggered approach to competence and confidence more than anything else from pharmacists. Yeah.
That leads me on to my next thing, which I think is just a statement in that it's really interested that you guys have been given the training and education and state the guidelines and expertise, but for the Schedule 4s, you have to refer to us. And I, hands up, know far less than you on this matter. So I think it's, I won't open this can of worms, but I just think it's a really interesting takeaway. There's so much discussion about the interface between general practice and pharmacy and prescribing and things. You guys are brilliant at what you do. And I think it's just a thought. Sometimes referring back to the GP, we've got the magic pen, right? But I just think that's a really interface when people are saying, well, pharmacists, should be doing this, that, and the other. Well, actually, here's a beautiful example of actually how you should be doing it, and you're doing it really well. And referring back to us, you're going to get someone who knows less. I've asked you guys for the information. I just thought that was quite an interesting thought to put out there into that discussion, not necessarily to...
Let me address that real quick because there's a couple of things. One, RSCGP has also updated their guidelines for nicotine as well. But one of the things that I'm always trying to get across to my workforce is that when you are engaging with another health professional and either referring on or seeking advice or providing advice, be as prepared as you possibly can be. And my expectation from my members is that if you're going to refer somebody to their GP, find the GPs in the area who have an interest in this space. And if nobody has yet, just let them know, listen, we might start getting people in this space. When I refer them on to you, let's talk about it. It's no good to refer somebody to a person who is not yet prepared or perhaps not wanting to be involved in this space. And so this is a good opportunity for health professionals in this space to have an excuse to have better contacts with each other as well, just in preparation for when that demand comes, if it comes.
And I think as well, I'd be advocating for pharmacists to be writing a clinical letter with clinical advice to us. I remember in some of the early things, the community asthma nurses, that was something that I kept on saying. You guys are experts in asthma. If you're referring back to a GP who doesn't do a lot of pediatric asthma, your point of view, your experience, your assessment, your judgment, your advice is invaluable. Write it down, tell us. We seek education from multiple resources, and our colleagues are one of them. So I think that's something to firmly advocate back. If you've got knowledge, share it. Don't say, oh, it's the GP. Yeah, I probably don't know as much as you. So thank you for that. On that and my lack of knowledge, so illicit vapes are illegal, but you can pretty much get them in every second shop. What, am I missing something? Am I just naive about law?
Oh, this is a tricky one. I don't know if I want to answer this one, Jared, but okay, for context, you're not missing anything at all.
Right.
I think that from a pharmacy profession perspective, these reforms were quite rapid and they weren't the model that was advocated for by a large number of healthcare providers, by public health professionals. So I think my interpretation, and I don't want to put words in the TGL department's mouth, is that the systems and structures that are needed to enforce the regulation are not quite up to the standard that they need to be to adequately enforce and prevent vapes from entering the country. I do know that there is a lot of work being done behind the scenes. And I say that as someone who meets with the team every week. We are part of an ongoing national vaping reform project at the PSA. And so we contact our colleagues at the TGO weekly. We have a really good working relationship, but it's one of the questions that we keep pitching because we get comments about, uptake of dispensing of vapes in pharmacy is quite low. And so we actually have to come back with, because demand's not there. So you're not missing anything. I think that this is a long-term play and we sort of just need to be, as Jared said, prepared for when these products become less accessible.
Is it illegal to buy an illicit vape and use an illicit vape?
They are illegal products. I know that the Queensland government is in the process of enforcing stronger regulations for suppliers, so actual stores, that came through to me yesterday, and that bill is being presented into Parliament yesterday. So they are illegal products. but we see them everywhere. You see them at
Yeah.
games, you see them in places where you can't even really smoke, so you shouldn't be vaping, but they are accessible.
I say it from I'm thinking about a young asthmatic
Hmm.
teenager who we're trying to educate on this, and motivational interviewing 100%. I thought it was covered really brilliantly by Jared. Um, but sometimes with teenagers, more and more, we forget that we're the adults, and sometimes we have to explain rules to teenagers. If you've got teenagers, you know what I'm talking about. And it's not like rules ever made teenagers comply, but there's a certain set of teenagers that if a doctor or healthcare professional is saying, hey, just remember, it's actually illegal to do this, that can stick. It won't necessarily make them not do it. Same as drinking alcohol would be illegal, having sex is illegal, you know, having a social media account is illegal. But I quite like a balance of the rough with the smooth. Hey, I'm your pal. Here, I'm here to support you. Hey, how can we help you? With, by the way, I'm I'm seen as an authority figure. I don't like coming over as authoritarian, but I think sometimes you forget your power in that role to say, "Hey, I'm not arresting you. I'm not the police. I'm the friendly person you chat to about your whole health issues. I'm just letting you know this is legal. Um, you know, you should be aware of that." And that's sort of how I phrase those things, as opposed to with a punitive point. I just wanted to really be clear on that because, yeah, I didn't know.
Yeah, I
Um,
think it's important to point out that the regulations as they stand, they don't necessarily enforce any legal ramifications for people who purchase them, as far as I'm aware. It's more for
hmm.
those people who are selling them. So
Yeah, and I think sometimes that lack of clarity can be useful as well. I think sometimes just
yeah,
saying
true.
it and highlighting it can
These are
say,
illegal.
and if we're just a teenager going, oh, I'm not going to get arrested. Yeah, you're not going to get arrested. Just saying, you know. I had a couple of practical questions. I sometimes do have an adult say, "Hey, I vape," and they give me a number. What's a lot of vape? What's a cigarette equivalent? So everybody knows pack years, everybody knows what a lot of cigarettes is. When you're assessing someone who, let's just go with a 20 pack a day smoker, which is how we quantify in medicine and pack years, what's the equivalent in vapes?
It's hard to find that, and part of the
Mm.
problem is that many of the black market vapes don't contain the amount of nicotine that they claim to. In fact,
Mm.
one of the reasons that we have no nicotine vapes as Schedule 3 and Schedule 4 is because the day that they said, oh, if it contains nicotine, it's now a scheduled product, all the products had stickers put on them saying nicotine free, and so it's really difficult to get that perception. I will say this: in countries where they are regulated as a consumer product, the average strength tends to be around between 10 and 20 milligrams of nicotine per device. And they will usually use that in about a week. But the problem that we have here is that most of the products that have been available in Australia, and also those products tend to be available in Southeast Asia, which is where most of our, say, overseas students are coming from, who come in with, nicotine dependence from vaping. They're getting devices that are significantly higher in strength, and also the bioavailability of them is much higher as
Mm.
well.
Okay.
So that's hard to say.
Yeah, okay. I'm very conscious of time. I think as a clinician, probably the way I would phrase that to patients is we have absolutely no idea what's in your vape and how that quantifies in cigarettes. So we really don't know the harm. I think I would just be very obvious about that. Right, let's move on to Libby's presentation. I could ask questions all night, but the whole point of this and having it in a pediatric asthma forum was teenagers, right? We've just seen the data there, and the rest to inform not only our asthmatic patients, but any of our pediatric patients, but a lot of it from adults who smoke in the home with asthmatic patients as well. So Libby is going to give us a case study of how this affects asthmatic patients.
Thanks, Kirsty. Hi, everyone. I'm Libby, one of the asthma educators at the Community Asthma Program in CoHealth. I also am on the working group with the Community of Practice and recently on the ICAM project in the sustain phase as well. So had a lot going on in terms of I suppose, pediatric asthma, and we were wanting to get an adolescent case study for tonight, but unfortunately, we currently don't have any children, which is actually a good thing, any adolescents on our program who are vaping or smoking. So instead, I am going to present a case study on a little girl who's currently one of my patients, who has a parent who's a smoker. So I'll give you the background. So Sadie's a 2.5-year-old girl who was referred to our program, the community asthma program, in June this year, post having a presentation to Werribee Mercy Hospital. She lives in the West with her parents and their pet dog, and she attends daycare 3 days a week. So a little bit about her past history, just to give some background. She had a history of bronchiolitis as a baby, and previous to coming onto our program had had 4 episodes of viral-induced asthma in the past year, all of which she'd unfortunately had to go to Werribee Mercy for, as well as then having follow-up with their local GP. And she also frequently gets eczema, which coincides with her getting unwell with her asthma. Since her recent exacerbation, so when I got to speak to mum in an intake call, she had been stable post her presentation and hadn't needed any further doses of Ventolin once she was discharged. Fortunately, given that she'd had quite a few frequent presentations this year, they did decide to start her on Flixitide Junior, so a preventer, once she left Werribee Mercy on her last presentation. So on discharge, she was given a written asthma action plan, the spacer and mask, some Ventolin, and also the Flixitide Junior. She then followed up with her GP within the week of leaving hospital. When speaking to mum, initially the triggers that mum raised were viral and changes in weather. However, mum then, as we were going through intake, then advised that she'd also noticed that Sadie had been getting some rashes and eczema from contact with their dog. And mum then disclosed as well during the education session that I actually had with them that dad was a smoker. She then explained a little bit of the history of dad's smoking, which unfortunately started when mum was pregnant with Sadie. And at the time, they were actually offered some advice and support from the midwife that they were working with, who suggested that if dad was to continue smoking, that he did so outside the house and wear a smoking jacket and maintain hand hygiene post-smoking, which he did so until Sadie was born. Post this, he continued to smoke, and then in the last year, mum then advised me that he had transitioned from cigarettes to smoking, and unfortunately, it's of the illicit type of vaping. From cigarettes to vaping, and it was the illicit type of vaping, not the prescribed ones, as he thought it was a better option and less risk to himself and his family, which was quite interesting. However, Sadie's mum disclosed that she found that there were quite often nights since Dad had taken up vaping when he had been vaping at home and then had contact with Sadie, and Sadie was then actually having some asthma signs and symptoms post this contact, which just coincided with her having like cough. So, when we look at it, it could be from that trigger or it could be from another trigger, but it was just interesting at the times that it coincided with, and the contact with dad post him vaping. Sorry, Kirsty, next slide. We then discussed this more, and mum at that stage was really keen for me to actually get dad involved in the discussions that we were having. So fortunately, we were given some recent education from our health promotion team at CoHealth. So I kind of had a little bit of knowledge on vaping and sort of what had been happening in that realm. So I was able to give Dad some information, even though I don't know how well it was received. So briefly during the education session, I was able to give Dad a bit of an overview of what's actually in these vapes that he's currently on. And I think, I'm not sure how much he's consuming daily, but I think it's quite a big amount. And was able to explain to him that they're aerosols that, like obviously what Jared and Nikita were saying, that consist of gases containing lots of different chemicals in them. And as with tobacco smoke, people in the vicinity of vaping, they can inhale secondhand vape emissions and may also be exposed to these chemicals from residue that's left on surfaces known as third-hand exposure. And I think that's something really important when we're thinking about parents and people who are smoking in either households or close to a home when there's children involved, and children we know with respiratory illnesses, that it may not be just them being there when the parent's smoking. It can be what's actually left on those surfaces that that child's then touching or exposed to post as well, that can have these other effects. Sorry, we go back to the other slide just for a minute. Sorry. The exposure, sorry, as well. I then also just explained to Dad, with obviously Mum being there too, that the vape, as well as we know cigarette smokes, the exposure to that can lead to increase in asthma, respiratory illnesses, middle ear infections, potential long-term effects on lung development, heart health, and even increased risk of learning difficulties, obviously, which Jared and Nikita also touched on. The third-hand exposure as well, where the aerosols settle on the surfaces, poses a risk to contact with skin, as it can be swallowed, making vape-free homes and cars essential for health. So I tried to reiterate this to Dad. He at the time did say that he was smoking inside as well as outside the home. Sorry, next slide, Kirsty. So then we discussed about different things that Dad could possibly do to help with Sadie if we thought that this could be something that could be contributing to her asthma triggers. It's really, really hard, these conversations to have. And I still can put my hand up and say as a clinician that I find these really tricky to have with families, but I know they're really important conversations to have. So I offered resources to Dad at the time, which he declined. But post the conversation, advised Mum, obviously, that the best place to start would be Quit Australia, because Mum was very much wanting to, for herself, have the knowledge that she needs to have, I suppose, for her family. Follow-up, I was able to speak to the family a week ago for a phone review, and Mum advised that Sadie was still on her Flixitide, so her preventer had been going really well with that. Whether it's just the consistency now of being on a preventer that's helping her, or that also positive to this was that Dad has actually now decided that he, at this stage, doesn't want to give up on his vaping, but is now vaping outside the home. He's actually wearing a jacket like he used to when he was smoking his cigarettes, and has been a lot more proactive with his hand hygiene and washing his hands post using his vape, which Mum was really positive about on the phone, about these simple steps that have been made just in the 5 weeks since I had last done education with them and spoken with them. And I think, like Jared and Nikita said earlier, that it's about starting these conversations and planting the seed and being empathetic and trying to help these families in the best way that we can, because it's not going to be a win every time, and it may be a few steps backwards and then one step forward. But I think it's really important for all clinicians to have some kind of awareness of not only cigarette smoking but vaping, and to know where we can point our families in the direction of to get more further support. Just when I was doing my research as well, I found a really interesting read, which was on the website Tobacco in Australia Facts and Issues. I've left the website there for people to have a look at. It had some really interesting information at the time when we were focusing more on the adolescent kind of focus for this session tonight. But yeah, it's there if anyone wants to read it. And yeah, thank you. That's mine. If anyone has any questions, more than happy to answer them.
Thank you so much, Libby. I think that is a brilliant clinical summary of how this should be approached. Really useful to see a practical awareness, because I think that probably is the biggest scenario. It's young people whose parents have maybe transitioned from cigarette smoking to vaping. Again, I'm sure we're all quite comfortable talking about cigarette smoking and cessation, but what do you see? What are the risks? How do you phrase that? So I think that's really useful. Of note, I don't think my policy of maybe raising the illegality of it would stand for adults quite as much. I think adults are aware of that and can often find that as a judgment. I think it's a sensitive, gentle comment that is useful for teens more than it is for adults, just to clarify how I would practice. Does anybody have any questions for Libby? I noticed somebody raised their hand earlier in the conversation. I don't know if that was just a slipped hand. Oh, Yvonne Muscat in this chat is saying, as his father is vaping in their vehicle, particles may stay in the upholstery. That's a fantastic point, Yvonne. Yeah, to say. Um, yeah, still smoking and vaping in cars still does astound me, but it is certainly a very common thing. So just all these little questions to ask. Just for those who aren't familiar with the community asthma program, Libby and I work quite a lot together, and if you use their service, an interface like that might look like Libby then saying, hey, why don't you go to the next GP appointment? Maybe he doesn't have a GP, writing me all the wonderful information she's told. I can then reiterate that. And then I can sort of, if we build up a rapport, say, hey, do you have a GP? Have you thought about it? Is that something you want to do? So that's how GP and community asthma program can really work well together to target that. So there's no more questions. I just had a practical question on prescribing in under 18s for Jared and Nikita. Oh, sorry, Jared's got his hand up. Being very patient.
Yeah, I was just going to make a comment with regards to talking to people about the things that are illegal, because in vaping space, it's actually useful for adults to hear some of the things that they don't quite know. So the first one is you can't vape where you're not allowed to smoke. That's illegal. And one of those places is in a car with a child. In Victoria, you can't smoke in a car with a child in it, and you can't vape in a car with a child in it. Now, it's not common for people to get pulled up on that, but you do see it in traffic stops where people are being pulled up. Why am I being pulled up? I wasn't speeding. You're smoking, and there's kids in the car. And vaping is affected by that as well. So while you don't want to say, hey, vaping's illegal, you might say to them, were you aware that vaping in your car with a kid in there is illegal? And they might go, is it? And then that can be an open to the conversation as well. So it's not about telling them the stuff they do know, because it's not going to work for an adult.
Yeah, that's a fantastic point. More information I didn't know. What is the youngest age that you can prescribe a vape for?
It's a little bit of a grey area. So technically speaking, there is no limit in our state and in some of the other states. So Western Australia and Tasmania, you can't use them under 18 at all. In the states where they don't have an age limit, you technically can prescribe as low as you want to go. Now, the main difference is the SAS application form. So I mentioned earlier we do this one called SASC, which is you're letting the government know, hey, I'm using this, thanks very much, and you're done. With anybody under the age of 16, it's considered to be experimental, and therefore you need an SASB form, which is not a I'm letting the government know, it is I'm waiting for the government to give me permission to write the prescription, and certainly not available Schedule 3 in any state at all. So you could make a case for, if you've got a 14-year-old who is very heavily smoking and nothing will work for them, but maybe they're going to, they've shown some interest and there might be some success with vaping, that could be done. I would suggest, I wouldn't feel comfortable dispensing that without a good conversation. So it's a specialist type of approach for whichever practitioner wants to get in that space. Yeah.
Fantastic. We've got a couple of questions here. Naomi's asked, what is the cost of prescription vapes compared to black market vapes?
Much more expensive. That's the reality as it is right now. There's two reasons for that. So people might be aware, for instance, about illegal tobacco as well. It is currently less expensive than cigarettes. And so this is an issue with the black market. The actual, like the real illegal stuff that is being sold by organized crime into these retailers, they're doing it very cheaply in order to get as much of the market as they possibly can. But in addition to that, the devices themselves are expensive, and the time that it takes to do it is not covered by Medicare. So if you're getting an S3 product from a pharmacist, it's more expensive than an S4. Most doctors that I know who are prescribing this space are not bulk billing it, and so it becomes an expense, and which means in the short term that's another reason that people aren't getting them. Yeah.
Thank you for that. And Charlotte's pointed out about this is nurses, but healthcare professionals smoking and working with children. Obviously, smoking amongst healthcare professionals, that's always been a thing on the breaks. At least we have no smoking in healthcare areas now. But I think that might be a useful thing to discuss if you have a colleague who vapes, that they may not know about these things. Difficult conversation to have. Obviously, we've talked about lots of ways you can bring up the conversation tonight, but I think even if it's just my lack of education that has highlighted things, healthcare professionals who vape might be genuinely doing it, obviously knowing now that there's risks if they're a healthcare professional, but not knowing about the second-hand risks to their children or people they work with. So maybe that's a conversation we can have. Okay, guys, we are almost out of time. So I will quickly run through health pathways. So just back on an asthma focus, Health Pathways has changed slightly. You now need an individual login. It's easy enough to set up, but if you haven't logged in for a while, the generic logins that you may have used in the past don't work. So just prepare to have an extra 5 minutes to set that up when you go. Asthma in children, the guidelines, been a few questions going through about age of diagnosis in young patients. You can actually find these within the health pathways, asthma in adolescents, and we have preschool, 6 to 11 and 12 years and older pathways. There's everything from acute asthma through to chronic management. There's some referral information there and referral criteria, really every resource that you need to know. And now you can get CPD for your health pathway use. Hurrah! So on this page under other related pathways, go to the CPD for health pathway use. Click on the link. My clicker has stopped working. And you'll see it down in the drop-down tab there. And then there's a simple form, very similar to the forms that we fill in on the ICGP portal, where you can report a reflection and what module you read. Sorry, I don't know what's happening to my clicker tonight. Yeah, if you want to sign up for Health Pathways now to save you some time in practice, there's a barcode there that you can use. Barcode showing my age there, so I'll let you have a second to look at it, the QR code. Or you can log on to Health Pathways tonight while it's fresh in your memory. And just a little bit of the community asthma programme who Libby works for. We've also attended from the practitioners a part of that programme tonight. Fantastic free asthma programme for any child up to the age of 18. The referral is embedded in Better Practice software. If you go into your letters, you can, in your documents, sorry, and go to write a letter, you'll find the community asthma programme referral. It's free service. I use it a lot. It's integral to my paediatric asthma management. And as I say, the feedback, the knowledge that is imparted, the continuity of care and the team care really is secondary to no service I have used in this healthcare service. It is also can be used as part of your chronic disease management plans. Obviously, you'll be familiar with the changes and then that happened in July. You do not need allied health now to create them. Asthma and all asthmatic patients, including pediatric patients, should have a chronic disease management plan to help support, and the community asthma programme can be an allied health provider with that. Olivia, is the poll question coming up?
Yep, just give me one moment.
Just while people are doing that, a quick question for the team. If it's a very good thing, if it's a smoke-free environment, such as a healthcare practice hospital, has the signage changed to say it's also vape-free, or is it meant to be presumed?
That's a very good question. As it pertains to the regulation, it is presumed, but I've seen a few signs that have changed in Canberra. Jared, I'm not too sure if you can comment about Melbourne specifically, but here in Canberra, it's inconsistent at this stage.
Most places that I'm seeing are saying both, just to clarify the fact that it is smoke and vape free. So I was at Caulfield's Monash University campus today, and they've got them everywhere. When you walk into the place, we're very proud to be both smoke and vape free, and that's the wording they use, both smoke and vape free. Yeah.
Great.
Yeah, I've seen the same combination of both. Yeah.
Hopefully Canberra catches up in that case.
From a legal perspective in Victoria, if a place is obligated to be smoke-free, it is also obligated to be vape-free. So from that perspective, yes, they definitely are. But if you're voluntarily smoke-free, they might still be vaping, maybe.
Okie doke. Thanks so much, guys. Lots of thanks coming in from the chat. The general consensus, it was very good and very informative, which it was. It was fantastic. Thank you. So your feedback is really important to us for these sessions. If you could take a second to scan the QR code and give us some feedback via SurveyMonkey, that would be really appreciated. You can also share what other things you would like to be discussed at future community of practice meetings. And the next community of practice is Wednesday, the 12th of November. The registration link will be sent out. And it will be on allergic asthma and thunderstorm asthma. I don't think we have that up on the slide, but we have agreed November is our time to review our allergy asthma, thunderstorm asthma protocols and everything linked with that. So we look forward to welcoming you then. Thanks so much.